Good afternoon, one and all. We have another important panel discussion on the second day of Diagnostics Leadership Summit. This is going to be role of CBC and ESR in chronic disease management, a very important topic to be discussed. And we have a very eminent panel here to discuss the same. We have Dr. ANIL, Senior Director, Hospital Laboratory Services, BLK Super Speciality Hospital. Thanks a lot, Dr. Anil, for joining in for the session. We have Dr. AMRIT Kaur KALER, Professor of Pathology, TOMCH Fellow, Strand Life Sciences, HCG Bangalore. Dr. Amrit, welcome, and thanks a lot for moderating the
Thank you.
session, for accepting to moderate. Yeah. And we have Dr. Sambat here, Sambat Kumar, KJ, Head of the Department Hematology, MD, PDF, Vijaya Diagnostic Center. Welcome, Dr. Sambat. And we have Dr. Shelly Mahajan, Clinical Head, Caring DX Mahajan Imaging. Welcome, Dr. Shelly. We have Dr. Amrita Singh, Chief Pathologist, North and East India Newburgh Diagnostics, who has joined. Thanks a lot to each one of the panelists for joining in for our afternoon session and to talk about the role of CBC. Over to Dr. Amrit for the session. And one small request, please mute yourself when you're not talking so we can avoid background noises. Thank you.
Thank you, Pratibha, for organizing this session. Knowledge is always best when utilized in the patient management and treatment. Anemias, as we already know, that it has been a very important problem in our country, especially in developing world. But anemia of chronic disorders has been left really untouched since long time, since thalassemia and hemoglobinopathy has taken a upper hand over the diagnosis in anemias. So I think it's time to know the etiology, the pathogenesis, and what goes behind the diagnosis and what is required for the management of these chronic anemias. So I will just share two slides which I have prepared just to make sure that the pathogenesis is clearly understood. So I'll just go to my presentation. Yeah. So the today's topic has already been introduced. And what is anemia of chronic disorders? These are basically known as hyperproliferative anemias, or they have been recently been classified as anemias of inflammation as well. And it is the second most common cause of anemia in India, especially after any iron deficiencies anemias. And it has been prevalent even in the elderlies, even in kidney diseases, even in the cardiovascular diseases. So it's very important to understand what goes behind. And in 77% of the elderly in India are affected by anemia. So there are multifactorial etiology which goes behind these types of anemias. So on the right side, I have shown what can be the associated diseases, which includes infections, inflammations, malignancies. In malignancies, especially multiple myelomas, CLLs, and even in autoimmune disorders, rheumatoid arthritis, SLEs, and renal and heart diseases. So this is a table which is very, very important to understand what happens in anemia of chronic disorders. So even though the patient is absorbing an adequate amount of iron, the iron is unavailable for the utilization in the erythropoiesis. So let's see from the left side of the table what happens. If there's a hypoxia, there's a release of EPO, which is erythropoietin, which is normally a reaction, or you can say a physiological response of the body towards hypoxia or anemia. But what happens in anemia of chronic disorders? There is no response of EPO, and the patient is not able to produce enough amount of EPO from the kidneys, and there is no stimulation of the marrow to produce the enough amount of RBCs. So this is one reason. Second is inflammations. Sometimes in the chronic inflammations, it releases interleukin 6 or BMP2, 4, 6, 9 based on different inflammations. All these markers, they go and act on the liver. So what happens in the liver? Liver releases hepcidin. Now, hepcidin is a hormone which is very important for the metabolization of the iron, which maintains the normal hemostasis of the iron inside the body. So when hepcidin is inhibited or when hepcidin is increased, it has a different effect on the metabolism of the iron. So let's see, it inflammation and hypoxia, it goes and inhibits the release of hepcidin. Now hepcidin, because of the increased iron in the body, hepcidin is decreased. So hepcidin actually goes and stops the absorption of the iron from the duodenum. And also, it reduces the availability of the iron from the macrophages. So it actually, combines with the ferroportin and does not allow the macrophages to release the iron from the macrophages to be available in the circulation to be utilized by the bone marrow. So, with the result, decreased absorption and decreased release from the macrophages leads to the low iron content inside the body. With the result, it is not available in the bone marrow for the utilization of erythropoiesis. And also, as we know, interleukin 1, tumor necrosis factor, interferons, they all act against EPO release from the kidneys, and they also inhibit. It's not available. It's not inhibition. It's not available for the stimulation of erythropoiesis. With the result, there's a decreased production. There is a reduced survival of even our RBCs in the circulation. So what happens is, even though the iron is present in the body, it is not available for utilization, which is known as a functional iron deficiency. So, which is also known as hypoferemia. So there is an increased iron, impaired production of EPO, and the blunted response to EPO and the reduced survival of the RBCs. Now, there are so many compounding factors which are, present with anemia of the chronic disorders. They can be like, you have iron deficiency anemias, you will have nutritional anemias, you will have bleeding, and you will have another medications and sometimes CDAs, which are, compound, and they cover up, they mask the anemia of chronic disorders. So with the result, as we know, there's a decreased iron availability. Now, I would like to give a question to Dr. Sampath. What do you think? How do you think that these patients present itself? Dr. Sampath, over to you.
Yeah, sorry, ma'am. Sorry. Am I audible, ma'am, now? Am I audible? Hello?
You're audible now. You're audible now. Go
Uh,
ahead.
Thank you, sir. Thank you. Thank you, ma'am. And first of all, I would like to say thanks to organization and everyone for giving this opportunity to discuss such a common and one of the toughest topic which usually we encounter in our regular practice. I just before going to the actual my clinical presentation, I just would like to summarize what Madam said. Is a chronic anemia of chronic disease is not a single disorder. It is a contains a group of heterogeneous disorders, just like chronic infections, autoimmune disorders, rheumatoid arthritis, connective tissue disorders. All this make leads to anemia of chronic disease. As Madam said, anemia of chronic disease is one of the second most common anemia of iron deficiency anemia. And most of the this one misdiagnosed as iron deficiency anemia. And also the incidence is usually increasing with age. As Madam said, exact pathogenesis still it is not known exactly. But study says this, especially interleukin 1 and 6 tumor necrosis factor and this acute reactant like pepsin may inhibits the release of iron from the macrophages. This is one of the important steps which is useful to differentiate for iron deficiency anemia. Coming to the clinical presentation, times iron deficiency, this anemia of chronic disease usually asymptomatic. These anemias are diagnosed when this diagnosis may be unexpected when they came for regular checkup or maybe part of evaluation of underlying clinical pathology. And severity of anemia is proportional to the underlying pathology. The clinical presentation manifestation of this anemia of chronic disease vary depending upon age, onset, and severity of underlying pathology. One of the commonest symptoms usually they presented fatigue, sweating, breathlessness, pallor, stress, and tachycardia, and sometimes they may land up into the congestive heart failure. As these symptoms are vague and non-specific, and they're common for all the anemias, it is difficult for clinicians to conclude for exact etiology and based on clinical findings. So clinician must have meticulous to find out the medical history and also physical examination, like medical history such as family history, whether is there any inherent property or diet habits, alcohol consumption, any medication, any past history of medical illness such as any renal disorders or hypothyroidism, any connective tissue disorders. All these are important for the clinicians to derive for conclusion, and all physical examination. Physical examinations like a hepatosplenomegaly and lymphnopathy, these are all important for the clinicians, which is useful for clinicians to derive one entity. As the clinical symptoms are very vague, so clinician must clinical history and physical examinations. These are important.
Yes, absolutely, Dr. Sampath. I think whenever we have any anemia of chronic disorders like SLE, rheumatoid arthritis, or you have some many malignancies, you should investigate the patient further about the iron studies, just to see whether the patient is also having some anemia, normocytic normochromic anemia in these patients. So it's very, very important, I think, to investigate them further.
When it's
Dr.
not
Amrit,
audible,
you're
when
muted.
voice is not.
You're muted.
Oh, sorry. So this calls for the further question that how to diagnose these cases, how to investigate further these anemia chronic disorders. And for this, I have Dr. Amrita Singh, Chief Pathologist from Elets Diagnostics. Dr. Amrita, so what do you think should we do to diagnose these cases, or you can just tell us about the lab diagnosis of these anemias?
Hi, thank you, Dr. Amrit. So for the diagnosis of anemias, we begin with the basic investigation, that is the CBC or the complete blood count. Along with the CBC, we also do a peripheral smear. So what we usually see in a CBC and a peripheral smear in anemias of chronic disease is that it's usually a mild anemia, and usually it is normocytic normochromic. In anemia of chronic diseases, the hypochromia comes first, whereas in anemia in iron deficiency anemia, it's the microcytosis which comes before the hypochromia. There is a very mild anisopoikilocytosis, then the reticulocyte count is low. The RPI or the reticulocyte production index is less than 2. Plasma iron is reduced. The total iron binding capacity is reduced. The transferrin saturation is low, and there's normal or increased serum ferritin levels. Coming to the other counts, like platelets are normal, the total leukocyte and the differential leukocyte counts are normal, except if in cases of other infections, then the counts may be deranged.
Yes, absolutely, Amrita. I think whenever we get a slide on in hematology department, sometimes you get normocytic normochromic anemias many times, and sometimes they are compounded by iron deficiency anemias as well. So it becomes sometimes difficult to understand that it is which type of anemia. So in these cases, MCV, MCH, and MCHC will be almost normal unless confounded by iron deficiency anemia, which might be decreased. RDW then again is based on the different shapes and sizes of the RBCs. And I've seen some of the cases of anemia disorders which also show there's a disturbance. Can somebody please mute themselves? Yeah. It's not only normocytic normocrominemia. You can see microcytic hypotomic anemia if there is associated iron deficiency as well. So RDW is again it's normal, and it might be increased in cases of iron deficiency anemia. And then RBC count is also on the lesser to normal side in these specific cases. And as you said, because since it has an overlapping features, I think serum ferritin and serum the transferrin assay, the TIBCs, these are very, very important factors to consider in these specific cases. And serum ferritin is, as usual, a acute phase reactant, so it will be normally increased in inflammations, but they will be reduced in iron deficiency anemias. And serum transferrin assays are something which has come into recent picture very recently, that the ratio of this transferrin assay to the serum ferritin is important to differentiate anemia of chronic disorders from iron deficiency anemias. So I think there are a lot of parameters, and I think I will ask Dr. Sampath to enlighten us to how to differentiate what can be the differential diagnosis at this case, and how do we differentiate them based on CBC parameters. Over to you, Dr. Sampath.
Thank you, ma'am. Thank you so much. Ma'am, as we all know, this diagnosis of anemia of chronic disease based on underlying alteration in iron hemostasis, along with the clinical and biochemical evidence of inflammation. But it's often difficult to diagnose differential diagnosis iron deficiency anemia. But certain extents we can differentiate iron deficiency anemia from anemia of chronic disease based on both clinical and biochemical parameters. When it is associated with, especially associated with iron deficiency combination, anemia of chronic disease here with associated with iron deficiency anemia, it is really challenging for pathologists to differentiate iron deficiency anemia. But there are certain parameters. These parameters are still under evaluation. The parameters are percentage of hypochromic cells and reticulocyte hemoglobin percentage and hemoglobin content. These are important parameters which useful to differentiate iron deficiency anemia from when it is associated with the anemia of chronic diseases. But these are still under evaluation. So more prospective studies are required to evaluation of the significance of these parameters in the real practice. Coming to this, as a pathology lab, we won't get always biochemical parameters to differentiate anemia of chronic disease. Most of the times we rely on only peripheral CBP parameters. It is a really difficult as a pathologists who working for standalone labs. So I just wanted to this is like usually we approach, when we encounter such cases in my practice, there are certain parameters called MC, mean corpuscular volume, RDW, reticulocyte count. These are important parameters which may give clue to the pathologist where we are going. For example, I just simplified and based on MCV, I into three categories of this anemia of chronic diseases based on MCV. One is microcytic anemias, normocytic, and macrocytic. As normal value is like when it is more than 4, we call macrocytic. In this category, consider MCV is more than 104, we have a differential of B12 deficiency, refractory anemia, and this hypoproliferative conditions. Usually, we consider these three possibilities in a common practice when there is a high MCV value. Similarly, macrocytic picture, when there is MCV value less than 75, we have a differential of chronic blood loss. Example like menstrual irregular inflammatory bowel diseases and alcoholic gastritis. And there's another iron deficiency in in dietary supplementation. And there are certain examples of intrinsic causes of hemolytic pictures like hemoglobinopathies. This most of the hemoglobinopathies have macrocytic pictures and targets, which will give us clue. So this is a possibility of like hemoglobinopathies. This and the third category is normocytic anemia. In anemias, most of the in this category, this normocytic anemia of chronic disease is usually associated with systemic disorders like autoimmune disorders, rheumatoid arthritis, and chronic inflammation, hepatitis, and renal disorder. But unfortunately, these are most some may associate with iron deficiency anemias. So, which is difficult for pathologists to differentiate iron deficiency versus this associated with chronic anemias. So in addition to this MCV, we have other parameters we consider is RDW and reticulocyte count. RDW, as we all know, this is indicates degree of anicytosis, which is increased classically in iron deficiency anemias, and it is normal or low in thalassemias. Next is reticulocyte count. Reticulocyte count is also one of the parameters which we usually consider is it indicates the proliferation of marrow cells. It is usually low or it is normal in case of hyperproliferative disorders, untreated iron or beta. So all these parameters we cannot interpret based on all these parameters we cannot interpret based on one parameter. So we need to combine these parameters to derive for conclusion. For example, there is a high MCV with a low reticulocyte count. I have a differential of either B12 deficiency or refractory anemia. In contrast to, there is a very high MCV with a high reticulocyte count. I have a differentials of marrow-infiltrative pathologies. These are usually we consider. And I was told that, like suppose if MCV is more than significantly high, the most possibilities, like what I was learned is like my teachers, my faculty, they said the MCV is very significantly high. It is like more than 120. Most probabilities are associated with B12 deficiencies. When there is borderly, it is elevated with the chronic anemias. Usually they are elderly patients. Usually they are fall under refractory anemia. It's the entity of MDS. These are refractory of MDS. Similarly, have recently have done a study map like we had done on study on VCS parameters, volume, conductivity, and scatter properties of neutrophils and monocytes in asymptomatic B12 deficiencies. Where what we have done, we have taken of 100 patients of B12 deficiencies. We have excluded associated with the systemic condition and compared with the normal individuals of normal B12 levels, and we have found that a significant correlation of mean monocytic conductivity and volume, which is significantly elevated in isolated B12 deficiency of asymptomatic individuals. So we can detect B12 deficiency in early stage. This is almost I have finished my study. I am writing up this thing. Finished my writing also. I'm trying to publish the paper. And also these parameters also useful when there is associated with iron deficiency anemia. Usually when there is associated with iron deficiency anemia is MCV masked. But our these parameters, mean monocytic volume and mean monocytic conductivity, these all will not get affected by with associated with iron deficiency anemia. So like there are less indications on these parameters. So I feel this more prospective studies are required to evaluate of these parameters in the current practice to detect early detection of B12 deficient and any other chronic anemias.
Yeah, excellent. I think information, Dr. Sampath. And I'm sure that hepcidin assays are very significant. I know we are pathologists, but at some point, I think the biochemistry parameters have really helped us in differentiating in these particular cases. So even now, the recent advance of growth differentiating factor 15 has come into picture, which is based on interleukin 1, and it is found increased in anemia of chronic disorders, and which is found to be normal in IDA, iron deficiency anemias. And of course, the ratio of the serum transferrin by serum ferritin, if it is less than 1, it is ACD, and if it is more than 2, it is iron deficiency anemia. So these are something which we pathologists, I think we need to remember in case of problematic cases if we are not able to solve them, based on CBC. But I really miss the bone marrow slides, which are stained for Pearl's Persian blue, which will be rich blue, and nowadays
yes.
we are not doing that anymore. But I really miss that +1, +2, until +5 iron storage in the bone marrow that we used to see during
We
my
do that,
post
madam.
graduation.
We do for
You're doing it? Okay.
we do it
That's
for every,
good.
yeah, we do for every case.
Okay. All right. Okay. Then that's nice to hear. I think so. That finishes up and rounds up the lab diagnosis part of it and of pertaining to CBC. But I think we have other lot of inflammatory mediators which come into picture in the chronic anemias. So I think ESR is something which can be discussed a little in detail to understand what is the role of ESR in the diagnosis of the chronic anemias. So for that, I think I'll invite Dr. SHELLY MAHAJAN. She's a clinical lead from MAHAJAN Imaging, and she's a molecular pathologist too. I just came to know recently. And over to you, ma'am. Please tell us what is the clinical utility of ESR in the diagnosis of anemia of chronic disorders. Over
Right.
to you.
Thank you so much, Dr. Amrit, for that kind introduction. So when we talk about ESR, the role of ESR in anemia of chronic diseases, I think firstly we need to understand what ESR is and what's the principle behind an ESR test. So ESR stands for erythrocyte sedimentation rate, and as the name suggests, what happens in this test is that anticoagulated whole blood is made to stand for about an hour, and we see and measure the rate at which the red blood cells sediment down or settle down under the influence of gravity. Factors which influence these would be majorly, broadly two: the red blood cell characteristics and the plasma characteristics, right? When we talk about red blood cell characteristics, it would be size of the cell, shape of the cell, the charge on the cell, and secondly, when we talk about the plasma, it would be the proteins in the cell and the acute phase proteins, basically. Now, why I wanted to mention this is that that is the principle behind raising of ESR or increased ESR in anemia of chronic disorders. In anemia of chronic disorders, there is some acute phase reactants, most commonly, for example, fibrinogen, which are there in the plasma. And what happens there with that is that they interfere with, with the charge on the red blood cell. Fibrinogen, for example, is a positively charged large molecule, and red blood cells are negatively charged. So what happens is when that happens, when fibrinogen interferes with that charge, the red blood cells cannot sort of sediment together or form a roulet to sediment together. So that becomes a factor of why ESR is raised in anemia of chronic diseases. Secondly, anemia itself, low hematocrit, is itself a factor of raised ESR, because again, there is the roulet formation is much better when there is low hematocrit, and hence the cells sediment faster. So again, that leads to an increased ESR. Now, as far as role or utility of ESR in anemia of chronic diseases goes, is that it surely is increased in ACDs, but it cannot be used as a factor of diagnosis. A single ESR value cannot be used for diagnosis of an anemia of chronic disease. The reason being that there are multiple factors which may lead to this increase in ESR. As I said, any acute phase reactant in the plasma will lead to an increased ESR. Anemia itself would lead to an increased ESR. That said, the major role of ESR in an ACDs remains, as has been discussed in this panel already, is to differentiate between or help in differentiating between iron deficiency anemia and anemia of chronic disorders. Why is that? Because as discussed, the other factors, for example, reticulocyte index, both these anemias are hyporegenerative anemias. So the retic count may not be as helpful in differentiating the two. Secondly, the iron indices, serum iron and transferrin saturation. Both of these are, similarly changed in both these anemias. One thing that stands out is serum ferritin. All right, serum ferritin is itself an acute phase reactant. So it will be increased in anemia of chronic diseases, but it may not be increased in anemia of, iron deficiency anemia. So where does the role of ESR come in this picture? Now, if serum ferritin is very, very high in a case of a picture of these two anemias, if it's very, very high, we know that iron deficiency anemia is highly unlikely, right? If ESR is very, very high and serum ferritin is low, then we know it's a case of ACD. But what happens when serum ferritin is moderately increased? Then what do we do? Serum ferritin can, that is the condition of coexistence of these two anemias, coexistence of iron deficiency anemia with an ACD. So essentially, their ESR is used to sort of correct the increased serum ferritin values and assess whether it is only an iron deficiency anemia, whether it is only an ACD, or is it a combination of the two? Is it a coexistent condition? For example, iron deficiency anemia in the background of rheumatoid arthritis. So that's where ESR usually is beneficial in ACDs, but however, it's not really used in diagnosis of an ACD.
Yeah, that's a nice explanation, Dr. Shelley. But I just want to know what are the other technical aspects which need to be considered while measuring the value of ESR. But I'm always surprised with one thing: why females have a higher ESR as compared to men. So, and at least one thing we are. So leave the jokes part, but definitely, we would like to know the technical aspects of the measurement.
So, as far as technical aspects go, the gold standard or the traditional method of ESR, if we talk about the most accepted method, which has passed the time test of time, would be the Westergren method. Now, what happens in that is that the blood is pipetted in this Westergren tube, and it is supposed to be put to be standing vertically, absolutely vertically, for about an hour, and then a human eye sort of looks at the level of the sedimentation, and then the report is released. Now, there are multiple factors, multiple levels where errors can happen in this, technical errors can happen, starting from the blood collection, right? Under mixing of blood after collection, or if the test was, ESR was put after, for example, 5-6 hours of blood collection. So the time is very important. The test should be put within 2 hours or 3 hours maximum of collection of blood sample. So that becomes one area of error, one pre-analytic area of error. Secondly, if it's a manual procedure, then there are a lot of technical analytical areas where the errors can happen. Most importantly, how the tube is, it has to be absolutely vertical. In fact, there are studies that say that every 3-degree tilt of tube can lead to about a 30% change in ESR value. Secondly, the temperature. Temperature is also a very important confounding factor. Because with the rise in temperature, essentially the plasma viscosity would change, and that, as I said, is a factor in ESR determination. So that is also again a confounding factor regarding this. Then the time for which the tube was put there, it has to be within 10 hours for all the three phases of ESR to take place, starting from Brule formation to fast fall to slow fall. So these three phases again have passed the test of time. So these three have to be followed and have to be patiently, over before we take the readings. Then again, pipetting errors. If there is any bubble in the tube, the thing will it will change. Sunlight changes, exposure to sunlight changes the values. Then comes the reading part of it. Now, which is called the observer bias. Firstly, at what level we take the reading. Most importantly, Buffy codes. We need to know what a Buffy code is. We need to know that the reading has to be below the Buffy code. We do not include the Buffy code in our readings. Secondly, if there is any other event like hemolysis, it can be hard to differentiate where the sedimentation has happened and where does the plasma, which is again reddish in color in case of hemolysis, start. Then thirdly, also in case of clotting of bloods. Now, what happens in clotting is that fibrinogen would be used up in clotting. So there will be spurious hypofibrinogenemia, and that means that ESR will be spuriously reduced. Right. So these are certain factors which are essentially manual factors which need to be kept in mind, and the observer needs to know where the corrections need to happen, be it temperature correction or angle correction, vial collection, sample collection errors. So all of these need to be kept in mind and can happen very, very commonly if not taken care of.
Yes, absolutely. The pre-analytical things are actually very, very important in the proper, values and diagnosis. So, are there any recent advances, Dr. Shelley? I'm not recent techniques which are available for the determination of ESR.
Yes, absolutely. Like as I said, Westergren method is an absolutely manual method, which is, I think it was 1920s when it was introduced. Absolutely, as like every other, almost every test right now, ESR is also automated. There are automated systems for ESRs, which do use modified Westergren principles. Modified Westergren principles means that first of all, essentially the principle remains the same, but the sample is even EDTA vial is can be used for an automated system. Firstly. Secondly, the advantage, of course, like any automated system, would be that the technical errors, the manual errors are minimized. Especially how the test is put, how the pipetting happens, how the reading happens, all of that is minimized. Secondly, the time of the assay. Now the automated systems are such that in 20 minutes we can get the ESR reading, and it gives the reading every 1 minute after that. So, these have been validated against the traditional gold standard Westergren method, and that's the criteria behind it. Any automated system, if validated with, if properly validated with a traditional system, a manual method like Westergren, and they have their own automated corrections for various errors which can happen or various confounding factors. So these are very important very useful in certain conditions. For example, in a high workload lab, right, and where there is a high chance of error if it's all manual, like the whole day. Secondly, but that said, still Westergren remains the gold standard method and should still be used for confirmation of in certain clinical situations. For example, in case of anemia which is showing very high ESR, it should be confirmed with a gold standard with the gold standard Westergren method. Although you can go by manufacturer's instructions and see how the system has been validated and validate it yourself in your lab. Secondly, for example, in polycythemias, if the ESR should definitely be confirmed by a Westergren method. The idea behind it is that the ESR, if the method, the test is developed to determine acute phase reactants or acute inflammations in the body. While anemia, polycythemia, these factors sort of spuriously change ESR. So if we are really using ESR in any clinical decision making in terms of chronic diseases, then these factors need to be kept in mind, and the result has to be corrected based on this, and then the report should be given.
Thank you, Dr. Shelley. I really like the recent machines which come forward and save our time and give us results better. And definitely they need to be, compared with the normal results. But before we go to the acute inflammatory mediators, which is also my favorite topic, Dr. Sampath, I just came to know that Bayer Advia hematology analyzer has come, which is, I think the Siemens Health Care has introduced. It can actually measure the hypochromia of the cells, and it can also gives a value on the reticulocyte hemoglobin content. So that is something very interesting, because that will tell you that how much the hemoglobin is being utilized by the reticulocytes, and whether this is a immediate reaction or immediate process, or this is a chronic process. So that's something amazing which I understood today. So do you have a viewpoint on that? Do
Sorry,
you
ma'am.
have
Actually,
any?
I've not gone through completely.
Okay.
Ma'am,
But
what I
it's really
realized,
nice.
yes, ma'am. Maybe what I understood is like a percentage of hypochromic cells, which are the important one to assess the functional iron deficiency. So usually it basically the property of measurement of this hypochromia based on scatter property of the red cells. Usually if it's hypochromia, this cutoff is if the hemoglobin content is less than 28 per each RBC, they consider it as hypochromia. As you mentioned, this latest technology has come to measure this hypochromic cells and content of reticulocyte hemoglobin. It is really helped us reduce the effort of pathologists to classify these anemias and iron deficiency anemias.
Absolutely. Yes. Now, inflammatory mediators. There are so many acute phase reactants, which leads to the high inflammatory mediators. So, I think I was speaking to Dr. ANIL in the morning. He's a senior director hospital in the lab services, BLK Super Speciality Hospital. And I was so much interested, I thought we could have one big talk only on the acute phase reactants. So, sir, what are the other inflammatory markers which can be used in the diagnosis of the chronic diseases, anemia chronic diseases?
Thank you, Dr. Amit, for the kind introduction. And yes, of course, we did discuss it in the morning about the various markers which can potentially be used for differentiating various disorders which cause the anemia of chronic disease. Now, my work has been made a bit easy to answer you, because a lot of my predecessors talked about a lot of inflammation, a lot of markers there, which includes hepcidin, which includes erythropoietin, which includes other activities which happen within the body, which are getting influenced by a lot of other inflammatory cytokines, and they actually cause, the bottom line ultimately is that they cause increased hepcidin and reduction of erythropoietin, and that's the bottom line in terms of the mechanism of the disease per se. So the usual ones which we usually incriminate, especially in the anemia of chronic disease, there's one particular marker which people talk a lot about, and that's the C-reactive protein. And I'm sure all of you would have realized that it's one of the most glamorous markers other than the IL-6, especially in the recent COVID times, because everybody would just want to get a CRP and an IL-6 level done. So if you look at CRP per se, a test which was almost nearly 100-year-old, has come resurfaced primarily because of the COVID infections in the recent past. Now, when we look at C-reactive protein per se, it is a protein which is being synthesized in the liver, and this particular protein was called C-reactive protein because it was reacting against these carbohydrate moiety of the Streptococcus pneumococcus bacteria. And interestingly, this particular, the product actually which is coming out from the liver is actually affecting directly the hepcidin levels and causing the increase in the hepcidin levels, which eventually gives you the pathophysiology that was already talked about by my predecessors during this discussion. The other markers which are of importance, again, COVID has been something which has really got them into prominence, like interleukins, all the interleukins for that matter, which includes interleukin 1, 6, and 10 in particular. And of course, the other interleukins, which are also other markers which are important, will be the tumor necrosis factor alpha as well as interferon gamma. All these markers have their own responsible roles to play because they all have their specific roles which are defined with them, especially the ones when we're talking about tumor necrosis factor alpha, or for that matter, we're talking about interferon gamma. These particular markers have a specific role on the macrophages, and they actually ensure that the macrophage iron gets sequestered. For all practical purposes, the idea of an anemia of chronic disease in terms of its pathogenesis is primarily to prevent the availability of iron to the bacteria, and that was one of the thought processes which had come about at that point of time. And therefore, all these inflammatory markers which are there potentially have the roles to play with respect to these three things. One, which is with respect to the increase in the hepcidin level. The second is the macrophage sequestration of the iron. And of course, we're looking at the reduction of the erythropoietin levels. Of course, I can keep on going on and on with respect to the inflammatory markers, but as you rightly pointed out, that can be a separate discussion point altogether. And perhaps this is what would be sufficient to, probably incite the minds to keep reading about it further. And this is something which is very interesting, yes.
So procalcitonin also has recently emerged as a very good inflammatory marker. I was reading about it. What are your viewpoints on that?
So procalcitonin is an absolutely interesting marker. More importantly, it's found its place primarily for the sepsis, for definition of sepsis. In fact, you have higher sensitivity procalcitonins and higher sensitivity CRPs, which are now available in the market. Now, when we talk about procalcitonin, its primary role has been, so far restricted to diagnosis of sepsis. In fact, one of the earliest markers to go up. This particular marker is a protein which is actually excreted by the parafollicular cells of the thyroid, and therefore, when it comes in circulation, its high levels are always attributable to a septic state. Now, it is surely a marker of inflammation. The biggest problem that we face in the clinical practice is it's actually relatively an expensive test to do, and just one single point when you do, the procalcitonin, it may not have much of a value, especially if it is normal. So serial values are more important, and that's what a lot of people, miss out. Yes, procalcitonin is usually a marker of an acute inflammation. There's no doubt about that, and it actually gives you a very good insight, especially about the sepsis part of it.
Thank you, sir. Thank you so much. So please let us know, how do we treat this anemia of chronic disorders? What's your viewpoint? We want your expert opinion on that.
Okay, so anemia of chronic disease, with whatever experiences I've had so far, as a career in hematology spanning almost about 2 decades now, it's a diagnosis which should be a diagnosis of exclusion. So if you have clearly been sure about the fact that now, yes, you're dealing with an anemia of chronic disease, then there has to be a chronic disease, which must be underlying there. So first point you need to figure out is, what is that particular chronic disease? And if you are able to figure out the chronic disease, please treat the chronic disease, because if you treat the disease, the anemia obviously starts getting better. Other than that, there is always, the drug therapies which can potentially be given are the erythropoietin or erythropoietin cocktails, which are potentially given in these circumstances. And most importantly, when you are looking at reducing inflammation, that's what is the primary target currently for most of the people. You would like to have CRP levels which are lower than 10 in such cases, and you would also like to make sure that the hepcidin levels go down. Of course, there are lots of cocktails which are now starting in terms of research which is happening in this area. There are these anti-hepcidin molecules and stuff like that, which are still not in the market as of now, but it is potentially going to be coming up soon, because we are already going into precision medicine. And hopefully when these kind of drugs will be made available, this will actually help us to reduce the hepcidin in itself, and that invariably will actually help us reduce the anemia of chronic disease. Now, having said that, we also need to keep a few other things in mind, that there can be concomitant iron deficiencies and there can be other concomitant disorders like thyroid disorders, etc., where you can have similar kind of problems coming up. You may actually be thinking that it's an anemia of chronic disease, but basically it's the anemia which has happened where we have probably had a concomitant iron deficiency and we've not treated it. And fortunately for me, all of you already discussed a lot of things about it, where you have mentioned how you will diagnose a concomitant iron deficiency. And if you do find a concomitant iron deficiency, giving iron to the patient becomes extremely important, because otherwise you will not be able to get the desired results of treating the patient for the anemia of chronic disease. The other important aspect is a lot of times we find these patients of anemia of chronic disease, especially in patients who are undergoing chronic dialysis, or patients who are from the kidney department, generally the ones who have chronic kidney diseases. So in all of them, in most of them, in fact, they have reduced levels of erythropoietin, and therefore giving erythropoietin accordingly becomes very important. And I'm sure a lot of us are aware of the that typical Thomas plot where we would put up the soluble transferrin saturation and the other aspects to it, and try to go ahead and treat them accordingly, either with iron or without iron, and go ahead. As far as the transfusion part of it is concerned, transfusion is something which is restricted to only those conditions where patients do not have any other choice, because otherwise, if they don't get transfused, they will get into a state where they can have a cardiac compromise or other compromises in the body. In such circumstances, you would prefer to give transfusions, but they are generally something which we will want to restrict as much as possible. And the other important aspects which I wanted to touch upon was that, your differential diagnosis are very closely related to something like myelodysplastic syndromes, sideroblastic anemias, etc. And all of them have almost similar profiles at times. And sometimes you can have concomitantly these diseases in some of these patients. So what you were asking for, having a marrow diagnosis would at times become extremely important. And in such circumstances, getting a marrow examination done and giving the right diagnosis on the marrow and then moving ahead and treating the patient accordingly also becomes important. There is also a very interesting thing which has been found in a lot of patients, who are having anemia of chronic disease. They generally have concomitant vitamin D deficiencies, and I think most of us do, because we generally tend to stay indoors in air-conditioned environments. And it's been observed that if you give good vitamin D therapies to these people, their anemia also concomitantly becomes better. So it's important for people to realize that, anemia of chronic disease, I would rather call it a diagnosis which is probably something which we should be giving as a last resort. We should be first trying to figure out, do we have any other thing which is parallelly causing these problems? There is another very important aspect which we have found in our practice, at least for the last 4 or 5 years, pretty commonly. Drugs have started inducing anemia of chronic disease, like people who are on antitubercular drugs, etc. They have this pyridoxine deficiency and they start getting anemia. And then a lot of people would want to treat it like an anemia of chronic disease, little realizing that if you just give pyridoxine, the person starts becoming better. So all these aspects need to be looked into very, very closely before one is actually, just putting somebody on a label of anemia of chronic disease and started treating with either erythropoietin or maybe concomitant iron therapy. I hope I have been able to give you a majority of the therapeutic options which are available for this.
Thank you, sir. Thank you so much for sharing your expertise with us. It has been really a mind opener for in so many ways. I think I want to end the session, but I want to hear from you again very soon. I think I will like to thank Elets Technomedia Private Limited and eHealth Magazine for organizing this diagnostic summit. And I would also like to thank the CEO, Dr. Ravi Gupta, and my favorite, Dr. Ravi Kaur, and Pratibha and Vikram for organizing this session and bringing all of us together in finding out, knowing this disease and finding out the solutions towards it. Really, Dr. Anil, I think sometimes the pro-inflammatory markers, suppressing the pro-inflammatory markers can also help in some situations. That's what I keep thinking. But definitely, it was a very fruitful session, and I'm sure our audience were quite enlightened by it. And I would like to thank Dr. Anil, Dr. Sampath, Dr. Shelly, Dr. Amrita. Thank you for sharing your knowledge and expertise with us. And I have really gained a lot from all of you. Thank you so much.
Thank you.
Over to you,
Likewise.
Pratibha.
Thank you.
Thanks a lot, Dr. Amrit, for moderating the session so well and taking up the pains of asking questions to each one of the panelists, getting them all together, and giving us such an informed panel discussion. I learned a lot. It was very in-depth insights which was given by each one of the panelists here. Thanks a lot for that, Dr. Amrit. And we would like to give away certificates for each panelist here and the moderator for taking up the session. Deepak, can we have the certificates, please? Thanks a lot, Dr. Anil HANDOO from BLK Super Speciality Hospital for joining in and giving your valuable inputs, sir. It was a really deep insights which you had given to us. Thanks a lot for that. Can we have the other certificates, please, Deepak? Dr. Amrit Kaur Claire from Strand Life Science HCG Bangalore. Once again, thanks for the moderation. It was really done well. Yeah.
Thank you. Thank you.
And Dr. Sampath from Vijaya Diagnostic Center, thanks for joining in and giving your comments, Dr. Sampath.
Thank you.
And thank you. As we get into the next two slides, I will also say that next would be on the personalized medicine. Next panel discussion will be on personalized medicine. Thanks a lot, Dr. Shelly Mahajan and Dr. Amrita Singh, for participating. Thanks a lot to each one of you. Thank you.
Thank you.
Thank you. Thank you. Bye-bye.
Bye.
Thank you. Thank you so much.
Thank you. Bye, everyone.